Hi, everyone. Good afternoon, good morning, and welcome to this webinar brought to you by United States of Care and AARP. 1 year in, lesson learned in order to build a better healthcare system going forward. My name is Emily Barson, and I'm the Executive Director of United States of Care. Thanks for joining us today. I'll be your host for today's event. And before I introduce our panelists, I'd love to share a bit about United States of Care and what brought us here. United States of Care is a nonpartisan, nonprofit organization. We work to ensure that everyone has access to quality, affordable healthcare, regardless of health status, social need, or income. The healthcare system isn't working for millions of people in the United States, and our research shows that people want a better healthcare system in the wake of the pandemic. And in fact, that there may be an opening for reforms that weren't possible before. We do our work in a unique way. We go around the country listening to people's needs and experiences to center healthcare reform efforts around those needs. And we're tackling the challenges on 2 tracks. First, we're working in states to expand access to quality, affordable healthcare right now, because people can't wait for a perfect solution from Washington. And we're also working to create the conditions for longer-term change. We know we need a new national conversation and new innovative solutions to build momentum for federal change that people can rely on, that won't be overturned or in danger at every election. Last year, as the scale and scope of the COVID-19 pandemic became clear, we shifted our efforts to support the response, connecting leaders to resources, partnering for impact with groups like COVID Exit Strategy and Stay Home Save Lives, crafting multiple rounds of policy recommendations for both state and federal level policymakers, which focused on meeting people's needs during the crisis, and creating timely resources to support policymakers and on-the-ground providers and others in their efforts. More recently, we've been leading an effort to build vaccine confidence among unsure populations to help chart a path back to normalcy. 2020 was the deadliest year on record for the United States since 1918, when we battled a flu pandemic and were fighting World War I. In fact, deaths increased last year by 15%. 2021 will likely bring additional challenges affecting the health of our nation. As we all know, last week marked 1 year since COVID-19 shut down the country. We thought it fitting to take this opportunity to bring together experts to reflect on the lessons learned over this year and how those lessons can help us in our work to build a better, more equitable healthcare system going forward. Now I'd like to introduce our expert panelists. First, thank you all for taking the time out of your schedules to join us today. First, Dr. Jean Accius is Senior Vice President of Global Thought Leadership at AARP, our co-host for today's event. In that role, he leads a team in positioning AARP as a global thought leader by identifying emerging trends around the world, cultivating and elevating new ideas, forging global strategic alliances that become the foundation for collaboration, and sparking bold solutions to change systems and improve the lives of the global population as it ages. Dr. Patrice Harris, a psychiatrist from Atlanta, has diverse experience as a private practicing physician, public health administrator, patient advocate, and medical society lobbyist. She has served in various leadership roles at the American Medical Association, including as the 174th president of the AMA in 2019 and 2020, and is presently the immediate past president. Currently, Dr. Harris continues in private practice and consults with both public and private organizations on health service delivery and emerging trends in practice and health policy. She is an adjunct professor in the Emory Department of Psychiatry and Behavioral Sciences. Dr. Caitlin Rivers is a senior scholar at the Johns Hopkins Center for Health Security and an assistant professor in the Department of Environmental Health and Engineering at the Johns Hopkins Bloomberg School of Public Health. Her research focuses on improving public health preparedness and response, particularly by improving capabilities for outbreak science and infectious disease modeling to support public health decision-making. Prior to joining JHU in 2017, Dr. Rivers worked as an epidemiologist for the United States Army as a Department of Defense SMART Scholar, and she also serves on the United States of Care Founders Council. Dr. Bob Wachter is a professor and chair of the Department of Medicine at the University of California, San Francisco. The department leads the nation in NIH grants and is generally ranked as one of the best in the US. He's the author of 300 articles and 6 books. He coined the term hospitalist in 1996 and is often considered the father of the hospitalist field, the fastest growing medical specialty in US history. He is past president of the Society of Hospital Medicine and past chair of the American Board of Internal Medicine. He is currently serving as the interim host of the COVID-19 podcast In the Bubble, which is downloaded about 1 million times each month. For our attendees today, throughout today's event, please submit your questions for the panel using the Q&A function, which you'll find in the lower part of your screen. And we'll turn to those questions toward the end of our program, and I'll remind you then as well. Let's jump in with our first question. This will be for all of you, but I'll start with Dr. Rivers. Really, what are the top 2 or 3 healthcare or public health lessons that you and your organization learned over the past year?
There are a lot, and I'm sure we will spend a lot of time reflecting, but 2 I think that have really been elevated. I can't claim that they're new, but one is that preparedness is not optional. I think everyone leading into the pandemic, with the exception of preparedness experts, were thinking that probably we would get by without devoting a lot of resources to preparedness, and that if we, keep getting a lucky streak, then it's not something that we need to concern ourselves with. But we have seen this year just how devastating it can be when things go wrong. And the goal of outbreak preparedness is always to stop a small event from becoming a larger event, from becoming a pandemic. And that needs to be our focus going forward, making sure that we have the tools and the resources and the plans in place to stop things before they spin out of control. And I think that's going to be a big focus of policymaking in the coming next few years. And the second lesson that I would highlight, again, probably not new, but of renewed importance, is that you cannot get wrong your communications with the public. It is not just a one-way conversation where you are telling them what you want them to know or what you think they need to know. It's really an ongoing dialogue, especially when we're in the middle of an event that has lasted this long. It's something that we need to continue to iterate on and make sure that we have refined our approaches for not only communicating in a way that people can understand, but that we are able to receive their own concerns and their own perspectives so that we can address them. And I think that this priority remains top of mind right now as we continue the vaccination campaign. Reaching people who have questions, concerns is, I think, a top priority for the next few months, if not longer.
Great, thank you. Other panelists, Dr. Wachter, do you want to jump in?
Sure. Thanks for having me, and completely agree with Caitlin. I'll go in a different direction and say a couple of lessons are that our healthcare system, which often seems calcified and incapable of change, proved itself to be surprisingly nimble under the existential threat of COVID, and with the support of some regulatory and payment changes, telemedicine being the most vibrant example, where in most places, including my own, we went from 1% televisits to 70% televisits in a month. And as I looked at my own organization sort of pivot to just deal with all the challenges of the pandemic, it was amazingly quick for a battleship to turn around. So we're capable of change, which I think is comforting. And I'd say the broader lesson, telemedicine being a piece of this, is the importance of digital transformation. I got my vaccine a couple of months ago, and I was handed a little card that I guess I should invest in some tech and laminate it. But you can imagine a world. And early on in the pandemic, the government said, we want to know how many cases there are in every hospital. Please, record them on a spreadsheet and fax them into us here in Washington, D.C. I mean, it's just an incredibly antiquated system. And so you had Google and Apple build a wonderful contact tracing app, but it went mostly nowhere, partly because people didn't trust sharing their data, but partly because when they connected with public health agencies, which they needed to connect with in order to close the loop to do contact tracing, the digital systems, the technology systems in public health agencies were a lot of soup cans and strings. And so that, we need a digital infrastructure to support a modern healthcare delivery system. And I think we made some progress on that during the pandemic, but also showed some of the gaps that need to be filled.
And Emily, I'll jump in.
Please, thank you.
Dr. Wachter, I have my card as well, so I will join you in purchasing the stock for the laminating machines. And I think there's a thread there regarding technology that certainly we could have a broader conversation about that. And thinking about the acceleration of digital health. By the way, it's not my top three, but I wanted to follow up on that. I think that's critical. And as we think through technology and innovation going forward, I think we should make sure that we establish some foundational principles, one of which is centering equity. And so speaking of centering equity, I think a lesson, I believe, reinforced many knew that already, but we really need to have a broader approach to how we even think about healthcare and not the traditional stakeholders. So critical to a path forward, I think this is the first lesson, is that we are going to have a systems approach, a broad systems approach, and public health and mental health are going to have to be integrated along with all of the other systems, and we're going to have to center equity. The next lesson learned is that trust and data and science matters. And I think there's also a thread through the technology, because we have to collect the data, but certainly we need to be able to collect it in a way that we can disseminate it quickly and again, embrace technology. And again, getting back to equity, we have to make sure that data is collected regarding race and ethnicity and zip code. But again, trust matters, which brings me to my last lesson, following up on something Dr. Rivers said, and it was about communication. We have to make sure there is clear and consistent communication. But I think, and this is something that I think well, there are many things that we might do differently if we had to do all over again. But I think we need to communicate with horizon messaging. I think we sort of said, okay, for 2 weeks and then for 1 week. And that actually led to some frustration. And so perhaps we should think through including that time horizon. Being a psychiatrist and understanding human behavior, I think folks will do better if they know, what's a longer term plan. And I don't think we were able to do that. Now, sometimes you can't do that. You don't have the data. But I think going forward, we need to make sure we are thinking about time horizons in our clear and consistent messaging and communication.
And I'll chime in, and I totally agree with everything that Dr. Harris indicated, as well as with the rest of the panelists. I think we have an opportunity, and what I mean by that is the fact that there's so many lessons learned from the last year that we are really at a juncture. On one hand, we can actually think about solving some of these issues by putting patches around them, or we can really be bold and courageous and do what Dr. Harris just recommended, take a systems approach to addressing many of the issues that we've seen. From our vantage point at AARP, clearly this pandemic has had a disproportionate impact, particularly on older adults. If you think about it, roughly about 95% of all COVID-related deaths has been by someone over the age of 50. When you look at the nursing home and long-term care settings across the country, around 40% of all deaths has been from the nursing homes. We just released our AARP nursing home dashboard last week, and the number is still significantly high. While the rate of infections are declining, the overall total is still roughly extremely high at about 170,000 deaths as relates to nursing home residents, and also as relates to direct care workers who are on the front lines are essential. I think some of the lessons that we've learned over the last year really bodes well with what everyone on the panel has talked about. And I'll call it the 3 C's. One is connectivity, the second is coordination, and the third is communication. What COVID-19 has clearly demonstrated is the fact that we are all interconnected. And I think that really speaks well to the notion and idea and the need to address these issues from an equitable state of mind. What I do impacts you, what you do clearly impacts me. And that if we're going to recover from this pandemic, we're really going to have to take that interconnectivity approach in a very meaningful and intentional way. The other is coordination, clearly coordination across the sectors and at all levels of government. We've done some survey work at AARP, particularly around the vaccine rollout, and over 60% of Americans are very confused and frankly frustrated with regards to finding out where, when they can actually get their vaccines and how should they actually go about doing that. So we do have an opportunity to think about the coordination nature of this work in a very meaningful and intentional way. And then finally, communication, clear and transparent communication, the idea of trust. is critically important. And at AARP, one of the things that we've been working on is both being that wise friend and also that fierce defender. Whether it's our AARP.org coronavirus webpage that provides timely, up-to-date information, because of the confusion that is taking place across the country with regards to the rollout and the vaccinations, we've created state-by-state pages, so you can actually go on our website and actually find out exactly when are you eligible, where can you go, what are the numbers you can reach, what are the different links you can reach. It's been very nerve-wracking to hear from members across the country in terms of exactly how can they get access to this information in a very meaningful way. And then we've also been hosting town hall meetings, bringing leading experts, including Dr. Harris, who had a tremendous opportunity to serve on one of our panels, to talk to the members directly because they're looking for clear, accurate, and transparent information. So I think that the connectivity piece is critically important. Really think about the coordination across sectors and industries and at all levels of government to ensure that we're all in a line. And then finally, around communication.
Great, thank you. Thank you all for those. I think unsurprisingly, a lot of overlap, but also a lot of great insights and lessons that we'll get a bit more into on one of those, which we did touch on. And I'll have Dr. Harris kick us off, but I'm sure others may have thoughts. As you referenced, there's rightly been a lot of attention about the racial inequities, which the pandemic has shown a light upon, and they're not new to many, especially folks who have worked in healthcare and public health, but it has certainly become more illuminated. So far, most of the public policy response has been centered around collecting data, and that's an important first step in order to make informed policy determinations. And would love to, get your thoughts. Do we know enough right now, or, sort of where do you see some of the direction of policies and recommendations that would start to address some of those systemic inequities that are right now baked into the health system?
Well, clearly the data, are incomplete. And so we will have to make a commitment to collecting that data. We will have to make a commitment to technology so that we can collect the data. I'm sure everyone on the panel can agree that it's a bit frustrating that we are often acting on data that's 2 to 3 years old. And so we really have to update that infrastructure so that we can have accurate data that's more up to date. And then that data, of course, hopefully informs our policy. On the physician side, on the medical side, we do recommend treatment alternatives based on data. We don't always do that regarding policy. I always say we should make sure that our policy recommendations are grounded in some data, and that we actually continue to monitor those or the consequences of those policy recommendations. People have heard me say, inspect what you expect. So we are on that journey to collect that data. And then we have to make sure that we are looking upstream. We have to look at issues around structural racism, institutional racism, all of the structural determinants of health that then impact the social determinants of health that then impact the individual. And sometimes that means having difficult conversations. It means doing that individually. It means doing that from an institution standpoint. I know we are trying to model that at the American Medical Association. Again, we are all on our journey, but I think we have to make sure that we are looking at systems change. As I said earlier, we have to be committed to meeting people where they are. I belong to a group here in Atlanta, steering committee, the Atlanta Regional Collaborative on Health and Improvement. And we talk a lot about inverting the burden. Right now, for the most part, the burden is on the individual to figure out how to navigate our system, right? And as a physician, I can tell you that when I'm the patient, it's a struggle for me to navigate. It's complex, it's complicated. And so, folks who don't have as much experience and knowledge as I have, find it really difficult to navigate our system. So we need to build systems that meet people where they are, again, centering them, but again, thinking about the upstream determinants, and then whether or not there are good paying jobs. As we have looked at the inequities around COVID, again, COVID exposed what was already in existence. It was our essential workers who didn't have the privilege of working from home, who made low wages, who lived in multi-generational families, who used public transportation. And then as we think about who lost jobs, was certainly those folks as well. So we have to make sure that we are committed, number one, to gathering the data and then looking upstream at the systems that cause inequities before we are going to be able to solve the problem.
Other panelists want to weigh in?
On the public health side, I would say there are a lot of subfields of public health that make identifying and supporting people and solving structural inequities really key to their practice. I would say that has historically not been central in pandemic preparedness. And so I think in my subfield, our next move will be to take lessons from the other subfields of public health that make this really core to the way that they think and the way that they interact with communities, and try to take lessons from them to make sure that our pandemic preparedness plans have this as an important element going forward. So I think that will be on our agenda.
And I would chime in with a couple of points. One is that the inequities that we've seen over the last year, as many have mentioned, were not actually created by COVID. These have been longstanding structural issues. And COVID has just been a great revealer. It really putting that on the table to really show not just the inequities, but also to challenge us in terms of exactly what are we going to do about them. And going back to my earlier point about interconnectivity, addressing these inequities is in everyone's best interest. And what I mean by that is that the Kellogg Foundation and Autorum did a report several years ago, which was pre-COVID, but I think that it really is telling that if you were to advance equity, what we would see is that there would be a significant gain by close to $8 trillion to our overall economic GDP. So think about it, the opportunity to create an environment where people can live their fullest, best lives and contribute to society actually benefits everyone overall by nearly $8 trillion. If you were to actually look at this in terms of consumer spending, that would be an annual, roughly about $800 billion a year in additional spending in this country. And then when you look at tax revenues, for all of those who are watching today, you would see an additional $450 billion worth of tax revenue at the federal level, and over $100 billion in state and local tax revenue at the state level. So there's an economic imperative in addition to the moral and social imperative for addressing these inequities. That really, these inequities stifles our collective economic well-being as a nation, and that we have an opportunity to solve those in a very meaningful and intentional way. I think that there are some things that we're starting to see. I know that many states in particular created equity councils or created equity task forces. And the goal is to not just come up with a plan, but also come up with a solution to really start to address those. So the first question is, to what extent is the leadership within a particular state making equity a top priority? Because it impacts both the public sector, it impacts public health, it impacts the healthcare system, it also impacts private industry. So this is something that actually impacts all of us. The other aspect to that is one thing to create a blueprint and a plan, and it's something totally different to execute on it. Some of these issues are not necessarily new. And I think that if you were to look even within your particular state, there might be some solutions, some models that might be scalable. So what could we actually scale up in order to address these inequities in a very meaningful way? And I think that point about data collection is so key, because I don't think we fully understand or have an appreciation for the devastation, because we don't necessarily have full, accurate access to the data. But in order for us to move forward, we're going to need to have that complete picture.
Emily, could I add one more thing about the path forward on equity? Because I think heretofore the model has been, and I have participated in that model as well. So, looking in the mirror here, but I think our model has been, well, let's have, a chief diversity officer or a task force or a council. Those are critical, right? Those are necessary, but what is, I think, not negotiable is the fact that the leader and leadership has to own accountability, right? Because heretofore, we have sort of given the responsibility to solve the problem to the folks that are most impacted. When there's a gender equity issue, let's have some folks and let's have perhaps women, a committee and their allies. And I'm being a bit hyperbolic here, but to solve the problem. And then we sort of look at that group or that person, that office, that task force to then come back with the plan, and then often own the accountability for execution. And my recommendation is, I've talked over the last year when leaders, CEOs have asked me what to do, I say, you have to own this, right? And so you have to say that I'm holding myself accountable, I'm responsible, I'm committing the resources, and every one of my direct reports has some metric, some tangible metric regarding this issue. It will be different. There's no one size fits all. Certainly will be tailored based on the needs of the organization, but leadership has to own this, own the accountability, commit to real resources, and not sort of leave it up to the, chief health equity officer or the task. The AMA, we talk about embedding health equity into the DNA of our organization. Again, on our journey, no organization is perfect, but it is about the evolution of that. But certainly leadership has to be ultimately accountable.
Yeah, I guess I'd add, it's a fascinating time in American history in that, as everyone said, COVID has exposed things that were well known. I mean, when you look at the inequities of COVID, both cases and outcomes, they're no more striking than what you see for heart disease or hypertension or cancer outcomes or treatment of many different diseases. There are inequities. And COVID shone a bright light on it, and it happened to occur at the same time that there was a reckoning with racial justice in the United States. So it's sort of, if we can't get it done now, when are we going to get it done? It certainly raised it higher in the agenda. I think I agree with Patrice. I think it's really an important time to have metrics that allow for some level of accountability. And there, the issue of diversity versus equity versus inclusion, they're all interrelated, and yet they're somewhat different. So, changing the leadership structure is important, but not the same thing as creating equity in terms of health outcomes. Working in a large healthcare delivery system, we're looking very hard at what we can do. And yet I think there's a deep recognition that much of the problem relates to issues that are well beyond the purview of the healthcare system, as we come to understand the importance of social and socioeconomic determinants. One might argue that some money should leave the healthcare system to improve housing or to improve income equity or decrease disparities. And of course, that will be a battle, because every industry sort of thinks it needs all the resources that it has, and we all have lobbyists and figure out how to fight that. So to the extent that it stays within an industry, it's a little bit easier. If it's something in the healthcare world we can do differently, it's one thing. But if we determine that what really has to happen is we invest more in the schools or more in housing or more in income redistribution, that's particularly tricky for us, because where is the piggy bank? A lot of it is in the healthcare system. So you end up gearing up for a fairly big battle, which makes me a little worried about. You're hearing a lot of talk about this. It will be fascinating to see what actually happens when the really hard questions of moving money from one sector to another, or one profession to another, hit it, as they invariably will.
Thank you. Thank you all. Switching gears slightly, and we'll start with Jean on this. And you referenced certainly the deaths among older populations, as well as focused in the nursing home populations. And I think really the crisis that we've seen in nursing homes is giving rise to a conversation about models of care where, home is the new healthcare delivery setting, and, exploring different models with diverse consumers. And I'd love to hear from you, especially, from your perspective at AARP, what models you're seeing that might have a chance to change the landscape of care and how care is given, especially to older adults.
And I appreciate that question, Emily. We've been doing surveys since the 1980s, particularly to people over the age of 50, to get a sense as to, particularly as they age, what are some of their preferences and some of the things that they value. And I think no one would be surprised by this, that the vast majority of people would prefer to receive care in their homes and communities for as long as possible. And what we've seen, particularly in the nursing home context, is really devastating and tragic, whether it's the lack of opportunity to connect with family outside of the nursing home. We're very grateful to the Centers for Medicare and Medicaid Services that came up with some updated guidance that would allow families to reunite with their loved ones in nursing homes in a very safe manner. But if you could just imagine how devastating it has been for these residents and not having that connectivity to family. So as we move forward, clearly the opportunity to think about how care delivered in this country is very critically important. How can we ensure that the care that's being delivered is person and family centered? In the context of this conversation, I think there's a tremendous opportunity to think about how can we ensure that people can age with options across the continuum of care? And how can we ensure that care is more integrated to reduce some of the complexity in the system? We know that there's over 53 million family caregivers in this country. And many of these family caregivers are doing very complicated medical nursing tasks, like giving injections, giving wound care, tube feedings, and receiving little to no training on how to do so. I have a personal colleague who was a caregiver for her mom while her mom was alive, and she said she had to give injections. And she never knew whether or not when she gave the injection, if she was actually helping her mom or hurting her mom, because she never got taught how to do so. So we at AARP created the Home Alone Alliance, which provides tools to consumers and families on how to do some of these complicated medical nursing tasks. The other aspect of this too is the fact that through the stimulus package that was signed by the president last week, that there's more resources that are going to be allocated to the community that would allow people to receive home care and services and support in a very meaningful way. We also need to kind of think about how do we address some of the conditions for some of our direct care workers who are on the front lines, who are essential. 40% of the deaths in nursing homes was both residents and staff. And in many cases, those staff didn't have the opportunity or the choice as to whether or not they could work from home. So how do we ensure that there's working conditions, that there's adequate protective gear, that there's transparency in reporting, that the conditions are changing in a way that really meets the needs of older adults and also meets the needs of families.
Great, thank you.
I might add, sort of on the technology theme, we will have new opportunities to rethink the locus of care over the next 10 years. And but we've got to be really thoughtful about how to do it. Obviously, the payment system is going to be a player there, but so is kind of the overarching system of care. So if you think about that, if you think about it, a lot of care has been institutional, whether it was someone having to be in a skilled nursing facility or something having to be in a hospital, in part because the payment model supported them being in those places versus alternative places, and in part because the technologies lived in those places. The technologies needed to monitor people or to treat them. And I think we're entering a world where we're going to have many more options. The monitoring technologies are getting incredibly good and slick, and things that we used to require hospitalization to do can now be monitored while someone is at home. But the key there is going to be, has the payment system transformed to support those models? They're probably ultimately cheaper, and yet it's sort of cheaper to whom? And is the system sort of nimble enough to kind of be in the leading edge of these models? And the technology, it's one thing to say, all right, we have a sensor that can sense your heart rate, your blood pressure, your glucose. We can do IV home monitoring or home infusions. We can give you oxygen. But I can tell you, if you're the doctor in the emergency room and a patient comes in, and to admit the patient to the hospital, all you have to do is make a single phone call. Whereas to send the patient home to have their hospitalization occur at home with very clear literature, and much of which from Caitlin's organization, from Johns Hopkins, that shows that will cost half as much, be more satisfying to the patient and the family, and have outcomes that are equally good. But to make that happen, I've got to make 10 phone calls to the oxygen company, the IV company, the monitoring company. Or if it's not clear, all right, who are all those digital signals going to go to? And if the answer is the primary care doctor, that's not going to work. So creating sort of turnkey options so that it's just as easy for the patient to be monitored at home, cared for at home with family. That's going to be really an important part of our agenda for the next 5 years, figuring out how to make it essentially as easy for the patient to get care in a setting that I think in most cases, as Jean says, they prefer if we can sort it out. Thinking about payment models, organizational models, technology models, I think will change the locus of care for many patients, not all, obviously, some will need to be in institutions, but a lot of people are in institutions now because that's what the payment supports and that's what our organizational structure supports as the easiest way to go. It shouldn't be.
And can I build on Bob's point real quickly, Emily, if that's okay? Let's look at Medicaid as a payment model, particularly in the long-term care setting perspective context. Within the Medicaid world, if you need care, personal care, assisted with eating, bathing, dressing, you have functional impairments. The way that the Medicaid program works right now is the fact that you're entitled to nursing home care, but home care is optional depending on the state. It's an optional service, meaning the fact that the state does not necessarily need to offer it, even though many states actually do. But even within the context of offering it, there's a cap on the slots. So you may actually be on a waiting list. We did a report many years ago that found that for every one person in a nursing home, you could actually care for 2 to 3 people in the community. So if you take into account the fact that consumer preference is to receive this care to the extent that is reasonably possible in the home and the community, and if you take into account the potential cost savings for doing so, it would seem as the approach that we need to take. And I think that the stimulus package that was signed into law helps to move us more and more in that direction. But to Bob's point, the way that the payment model actually works is the fact that one option is entitled, the other is optional. So we still have an opportunity to really kind of think about how do we align that care with the preferences and the potential cost savings that comes as a result.
And Emily, I'll make one more point, and Bob made a great point about the administrative and regulatory burdens, and that always seems to be an afterthought. So after we talk about maybe different payment, delivery systems and all the other things, and try to streamline that, although we don't for the most part, as Bob says, then we typically add on another measure, right? Another administrative burden. And I joke sometimes and said, we should really insist upon the Marie Kondo, principle about, for every new metric or measure that you add, you have to take one away. Probably I'd like to say for every new one you add, you take 10 away. But we also have to think about that, because I think working in siloed systems and year after year and new legislation and new regulations, we just sort of add on. And we never look from a systems point of view. And we also need to make sure that we are measuring for patient outcomes. Oftentimes it's just sort of checkbox measures, right? And so I think as we think about the new way of delivering care, that's an important part of the conversation as well.
Thank you. And Patrice, we're going to go back to you and talk about the mental health repercussions of the pandemic on both adults and children, and get your thoughts on, the potential long-term effects of the pandemic on mental health, and, what will be needed by mental health professionals in order to most effectively do their work in supporting the country and the population in getting back to normal, so to speak, and knowing that these are going to be reverberating for years.
So another sort of fault line that has been exposed by COVID is the lack of a well-funded, well-resourced, integrated mental health infrastructure. And we are seeing, of course, not unsurprising or not surprising that the pandemic is having an effect on the mental health of our country. certainly folks are more isolated. There's increased loneliness. We talked about connections, and we have lost connections. And, as Jean mentioned, the session I did with AARP, I have to say, was probably the most profound opportunity I had to experience the loneliness and sometimes the despair some of those seniors were experiencing. And certainly that has been across the age spectrum. We've seen survey after survey talk about the increase in symptoms of anxiety and depression and stress. And also even some surveys have talked about increased incidence of actual disorders, actual anxiety disorders and major depressive disorders. So again, we are seeing this, and we are seeing this in the medical community, who, particularly those on the front lines, who especially early on in this pandemic, we didn't have the answers that we had now. And just speaking for physicians, I think Bob can say we like to have answers, right? We like to help folks, and that was very despairing for a lot of our colleagues on the front line who didn't have answers. And so many folks were dying. So this has all certainly impacted us in so many ways. And then many folks have actually lost loved ones. But I also don't want to minimize the grief and the loss for those birthdays and anniversaries and the inability, particularly for our children, to experience some of those rituals that they have been looking forward to. So here we have a problem. Now, I try not to be sort of a doomsdayer and say that, we are going to have a crisis that's unmanageable. But here I love Caitlin, and I think our preparedness colleagues can help us think through this. Now is our opportunity to prepare, right? We are in the acute phases right now, and folks are sort of just figuring this out. But after we get post-acute phase of the pandemic, we are going to have these issues. And so we should be thinking right now about our systems and what's available. I was on CNN the other morning, and I talked about families often have a plan of what to do when the smoke alarm goes off, or there's a fire, everybody, meets at a place in the front yard. Folks need to be thinking about, plans for our mental healthiness and wellness. And so I think this is a great opportunity for us, again, to highlight that. Unfortunately, though, our payment systems are not always in alignment with our needs, and this is getting better, but it used to be that if you saw your primary care physician on one day, you couldn't see the psychiatrist on the same day. And, we had such ridiculous payment disincentives to get that care. We have to address issues around stigma. That's still a huge issue. Parity is still a huge issue. I chair the AMA's opioid task force, and we worked on some pilot projects in states where the state health commissioners sort of looked at their commercial payers, and they were not always in compliance with state or federal parity laws. And so we have a lot of work to do here, in addition to thinking through a systems approach. And I like the framework that the Wellbeing Trust has put out, in that we think about promotion and prevention, and those are sort of the vital community conditions that are actually incentives for health in general, not just mental health. But we have to think about mental health from a preventive standpoint. And then, of course, coverage is key. We know that so many more folks were able to receive services for substance use disorders and for mental disorders because of Medicaid expansion. And so we have to make sure we are thinking and talking about coverage and Medicaid expansion. And then there's the issue around engagement, around the workplace, and all of the other systems that we've already talked about. We've talked about the data. We have to make sure that folks are getting evidence-based and science-based care. When we looked around the country at care for opioid use disorder, first of all, only 2 in 10 folks who wanted medication-assisted treatment, which is evidence-based for an opioid use disorder, were able to get that. And we even had some systems that did not provide that, saying that this was another medication and it, you know, you were still addicted. And so that's not what the science says. So we have to make sure we are focused on evidence-based treatment there. And then again, looking at outcomes, inspect what we expect, making sure there are data systems where we can see the outcomes, and all the while, again, centering equity. And one more issue I'll just raise, again, that has been highlighted with COVID is trauma. I am a child and adolescent psychiatrist. You know, we saw the landmark study with Kaiser regarding adverse childhood experiences. And so there's been some conversation about that, not enough. And now we're seeing now the trauma of COVID-19, the trauma of racial injustice. And so we are really going to have to make sure we are centering trauma in our mental health response beyond COVID. But we have to think about that now. It will be too late. You know, it is too late. It's almost too late now to think about that if we wait until next month or next year.
Thank you. And I know, I'm sure others have insights. I know we have a number of audience questions coming in and want to make sure that we get to as much material as we can. So we'll keep moving. One item, you know, as I shared at the beginning, we are getting into work around vaccine research and confidence and communication. We had recommended $200 million for a public health education campaign. And in fact, the American Rescue Plan included $1 billion to educate the public on the vaccine. And get that outreach to boost confidence. I wonder if, you know, this is such a huge topic and we will be doing more focused conversations around this, but a lot of you, your opening remarks discussed the challenges around communication as one of the lessons. And I wonder if in a rapid fire sense, if there's, you know, lessons we've learned about the communicating with the public that can help both inform this current urgent need and as well as you know, sort of how we think about talking about public health issues in the future. Yeah, Caitlin.
Maybe start by saying that oftentimes in public health, our goals can be fuzzy or a little underwhelming because we know how hard it is to do big things. So it might be something like reduce some outcome by 10% over the next 20 years, but that's not what we have here. We have an opportunity to set a really crisp vision for where we want to be in a way that I think people will recognize and be inspired by. We want to get our kids back in school full time in the next 6 months. We want to be able to get together with our family for Christmas next year. And I think really basing our public health messaging around those shared goals and that crisp vision is a really unique opportunity that we have here. And I think pointing out to people how they can participate in making that goal a reality by going for testing if you're not feeling well, by getting vaccinated. There's a lot we can do here, I think, around making it worth people's while and helping them to understand where we are going.
I just add, yeah, the vaccine strikes me as a sort of wholly different opportunity and that we need to take advantage of. We blew it last year with mixed messaging on masks, mixed messaging on testing, mixed messaging on the nature of the threat itself, and we just can't afford to get that wrong. We have this really miracle of these vaccines, how good they are, how safe they are. I think what we've started to learn, probably old news in the public health community, but relatively new for some of the rest of us, is you know, listen first before talking at people, because people will immediately push back if they feel like they're being lectured to. Try to understand their concerns, and some concerns about the vaccine are perfectly legitimate. Figure out who the key opinion leaders and influencers are. For some, it's going to be Dr. Fauci. For some, it's going to be their own physicians. For some, it's going to be someone in the clergy. For some, it would be someone in a respected leader in their community. For some, it will be some kid on a skateboard on TikTok. And we have to sort that out. I was impressed when I spoke to Andy Slavitt a couple of weeks ago about this, that they are ready for that. And I think, you know, the messaging has been pretty poor on COVID all the way around, but I think they get that, you know, we need Hollywood, we need sports stars, we need, you know, a very diverse group of people doing the messaging, and they're intentionally holding back on some of that for now because they thought it was premature to put out a huge campaign before the vaccine was available. and to community as broadly as it needs to be. But I think you can expect a very large, robust, and diverse campaign to start rolling out in April or May. I think the numbers that we're seeing in terms of people's willingness to take the vaccine are comforting. They go up with every survey. There's no longer a large gulf between what you see among Caucasian populations and communities of color in terms of willingness to take the vaccine. The one gulf that has emerged is by political party, which is sad, but probably fixable if leaders on the right endorse the vaccine, and Trump did yesterday, which is helpful. We need more of that. So, absolutely crucial. And it can't just be, this will save your life, although you would think that would be a pretty strong message, but also what it will allow you to do that you couldn't do otherwise, couldn't do safely, and how much less anxiety you'll have once you're vaccinated. I think those are really important messages to get out.
Thank you. To kick it to one of our participant questions, someone raised that they've personally observed during the past year the disparities in rural America, largely an unconnected, aging populace with decreasing resources, both extended family and societal, many areas lacking access to healthcare providers and systems. And so the broad question, but, addressing some of the concerns or the disparities faced specific to rural America. Maybe Dr. Accius, I don't know if you want to kick us off there.
No, I appreciate that question. And we've also seen a significant spike over time, particularly in rural America as it relates to the COVID-19 virus and some of the infection rates. And I think, again, these are opportunities to think about how do we really not just slow the spread, but really also do what we need to do as a country to really solve this in a very meaningful way. We had a conversation today about the locus of care. And I think that what Bob indicated earlier is a critically important part of the strategy for moving forward in terms of exactly not just getting the information, but also making sure that people have access to telehealth and the different types of modes of care. The other aspect too is also addressing the issues around broadband and internet access and being able to do that. I think is going to be part of the opportunity moving forward, is both in terms of the investments that are needed to be made in terms of our infrastructure, as well as in terms of the coordination that needs to happen across the country.
Great.
Yeah, and a study just came out today that showed that as we looked at where telemedicine was happening, it was more in urban areas where people start out more connected. But the promise of telemedicine and non-geographically dependent care it won't completely solve the issues of access in rural communities. You can't deliver your baby by telemedicine yet. You can't have surgery by telemedicine yet. But it should, if we get our acts together, it should solve some of the problems of access, not only access to basic and primary care, but maybe even more challenging access to specialized care. It's one thing, can you have a primary care doctor in a rural community? Maybe, but can you have a specialist, whether it's a psychiatrist or a cardiologist? Harder. And so telemedicine opens up the opportunity to provide more access to basic care and more access to specialized care. But as Jean says, we have to get the infrastructure and the payment model right.
Great. And I think we have probably one more question before we need to wrap up. Patrice, you had referenced, certainly the need for coverage and specifically talked about Medicaid expansion. One of our attendees, asked about how to convince governments to, like Georgia, where you are, to expand Medicaid, as well as looking at programs like the 12 months of Medicaid coverage for postpartum individuals to help all of public health instead of looking only at politics. And would love your thoughts on that.
I wish I had the answer to that question. As you know, I've spent a good deal of my career, in advocacy and on the policy side working with state legislatures, particularly here in Georgia and at the federal level. But I think, so first of all, we start with the needs of the community, right? And we start there. I really love the data also that Gene talked about. He talked about the dollars, and we have to make that case. We always have to make, the business case, if you will. But I think narratives are important. And I think having patients share their stories, or having our legislators and policymakers see the difference it makes when someone is able to get care for their previously untreated or undertreated substance use disorder, or bipolar disorder, or major depressive disorder. And I think even as we look at, we have to get out of our silos as we look at funding. And I realize that's easier said than done, but I know one of the major institutions, everyone would know, healthcare institutions, saw that after, I believe it was cardiothoracic surgery, patients who had untreated depression stayed in the hospital longer, right? And they actually returned to the hospital, earlier than the 30 days. So I think it's gathering that data, which we need, but also telling the stories and how it matters. And I always say, I say that a lot here in Georgia, but across the country, businesses want to come to your state when potential employees are healthy and well educated. And so that makes a case for, in my opinion, it makes a case, or helps make the case for making sure that everyone has access to affordable, meaningful coverage.
Yeah, and certainly we've seen the incentives built into the American Rescue Plan, which try to address what you said, the business case, and making the bottom line add up for states as well, to see those benefits. And we've seen that when voters have the opportunity to weigh in on this directly in some of the states where that's been brought up to the ballot, has also been, reflective across demographics. And I think certainly, as you said, some of the narratives and really reflecting people's needs and unmet needs are powerful. We've also had someone from the audience saying, Patrice, please come help with Medicaid expansion in Texas too. So I think your services are in demand. We are coming up to the top of the hour and want to keep everyone running on time, but really just want to close with another huge thank you to everyone for tuning in today, and especially to our expert panel, Gene Accius, Patrice Harris, Caitlin Rivers, and Bob Wachter, for sharing your time and expertise with us. Our next virtual event for United States of Care is going to be 1 week from today on March 24th. And we'll bring together another set of experts to talk about action steps to address patients' barriers to accessing virtual care, with a focus on older adults. So really apropos to much of the discussion that was raised today, and digging a little deeper on that. Look out for future discussions that do get more into that vaccine confidence and messaging that we've also gotten into today. And just really encourage all of you to go to our website, unitedstatesofcare.org, to access the information referenced, as well as a deep body of resources available to support efforts for policymakers and beyond. If you aren't already on our list, please sign up so you can get notices about future events. And hopefully you'll consider joining us at a future event virtually for now, and hopefully one day not too far away in person again. We know that entering the next phase of the pandemic and a successful recovery will require all of us. And so we look forward to working with all of you, policymakers, advocates, and concerned people, as we strive in the midst of a public health crisis to work to build a healthcare system that can withstand the next one. Be safe, take care, and thank you.